So, good morning, everybody. Thank you very much to be here. This is a new complete ESD case of the ascending colon using traction strategy with the attract device. And we will see a relatively simple lesion in the right colon, uh, which is, you will see a benignant lesion, but when the resection seems easy and relatively quick, ESD is a good way to achieve a R0 resection and reduce the number of follow-up that will be needed. So we are here in the training in practice part of the ESD school to see full-time procedures with comments without any cut. So it's the complete procedure from the beginning to the end. And we are going now to this procedure. So first, you can see the valvula at the bottom of the picture, and we have this lesion, which is in the right column, not so far from the right angle, and it's not so easy to see it completely without using the cap to explore the lesion. And finally, we will see better the lesion using retroflexion, which is for me uh, unavoidable even for the diagnostic of the lesion when we have this kind of lesion that are going on the two sides of the fold. To see it completely and to be sure there is no malignancy in it, no demarcated area of malignancy in any areas, you should do both direct approach and retroflexion to see the lesion and explore. In this case, it seems more difficult to do the oral incision by the direct approach. So first, for me, the strategy is to do the oral side first after injection. So you can see here my injection is not deep enough. There is an hematoma which is appearing despite the fact that I try to inject properly. It's sometimes difficult in the caecum. So you should stop immediately if you have this kind of hematoma. Here again. So I try again to find the good way, and when it is finally the good layer, blue one without hematoma, I can ask to the nurse to inject more strongly, but at the beginning she should be aware to stop immediately if there is an hematoma, because you will see immediately after my injection that it is a really a bad thing to have hematoma, because the blood is therefore going and going, and it makes your field of view less clear because of the blood. So when you have this kind of blood oozing through your hematoma, the best solution is probably to do an incision through the hematoma. So first, you should find the good layer before moving too much. So first, I try to reach really the submucosal layer, the blue one, and after, I will pass into the hematoma in order to cut it completely and make it oozing outside, because once it will be cut, it will be easier to see which vessel is bleeding and to try to obtain hemostasis of this area by doing coagulation. In fact, here it was a small oozing, and once we cut the hematoma, we clearly and quickly obtain the stop of the bleeding. And immediately after, I will increase my incision, doing a smile shape in retroflexion, trying to increase and to go to the top of the fold in order to make after my direct approach easier. So we re-inject and re-inject through the knife, which is the dual knife J. And we inject and try to do the complete incision by retroflexion, trying to reach the top of the fold. And immediately after, I will do my trimming and my first dissection doing retroflexion in order to facilitate the end of the procedure once the traction will be on side, because it is sometimes difficult if the field is not enough open to achieve the resection. So once again, I try to combine enlarging the incision to the top of the fold by re-injecting and doing it in retroflex position. And immediately after, increasing my trimming to enlarge the space and make traction positionment setup. I mean, if you have not done your trimming, it's more difficult to set up the traction device, because you can catch the muscle or you can catch the other edge during your traction device setup. So before putting it, please try to open the space by doing a relatively good trimming. In fact, you will save time by doing it before placing the traction device. If you want to put the traction very early, sometimes you will lose time because it's more difficult to set up, and sometimes also because you will do a wrong setup by catching something you don't want to catch. I mean the muscle or the opposite edge of your incision, the one you don't want to remove, which is the surrounding area of the lesion. So once again, please lose some minutes to do a very good trimming and a good dissection in retroflexion, and therefore you go back to a direct approach in order to do your lesion on the anal edge. In this case, we go back to the area which is already injected, do a small hole with the knife, and complete the incision thanks to the knife. At the same time, when I can, I remove water by suctioning in order to make the area more clear without all the liquid coming to the field. But here the gravity is not so bad. It's at the side of the lesion, not perfect, but relatively good. And once again, we will do the incision by trying to make a pressure on the mucosa, torquing the scope in order to have more strength on the mucosa itself, to do an incision which is deeper from the beginning. Because if you do a shallow incision, you will have to repeat and repeat in order to really reach the submucosal layer. But if you can do something which is a little torqued, which is able to cut deeper, it will be easier after to go into the good submucosal layer. Oh, putain. I'm sorry, my daughter is drawing just close to me and doing a lot of noise. I'm sorry. So once you do it, you try to reach the opposite side of the incision. And once it is complete, you do your trimming once again at the anal edge in order to increase the space to set up the traction device and to make it easier to catch the edge of the lesion without catching the muscle. So the strategy is relatively simple and always the same. Try to open the space in order to be able to fix the traction device on the edge without catching the muscle or the opposite edge. And sometimes in very difficult situation, you want to place the traction very early in order to change the shape of the lesion, but sometimes you do it too early, and therefore you will lose time, in fact, because it's more difficult to catch the edge properly without catching something you don't want to tract with the lesion. And once you have done it, I am asking to the nurse to give me the traction device, and every time I can, during the time she needs to bring back the device, I try to suction in order to save time once the traction device will come to the field of view. So here I suction. The lesion is relatively well injected, relatively high, thanks to the injection we have done. But if I do it without any traction, finally I will lose time because I will go really faster thanks to the traction. It will stretch all the fibers, and every knife cut will cut more fibers with traction than if I do it without any traction. So here it was easier to catch the uh, anal edge loop, not the fixed point, but the anal edge. So I decided to catch it because it was easy to catch and fix it on the anal edge of the lesion. Once again, trying to catch a kind of mucosal fold in order to avoid any cutting of the specimen due to the clip. So my first one is fixed. I will now try to see the second point, which is the fixed point. You can catch both the green or the blue one, which are connected with the white link. It's the fixed point of the device that will be the fixed point if I need to tighten the device during the procedure. So I catch it, fix it now on the oral edge of the lesion, doing a fold. Immediately after, because the lesion is relatively big, more than 4 centimeters in size, we will also do a 4-point traction with the 2 free loops, the green and the purple one, because it will help to tract the two edges, lateral edges of the lesion, which here will be a little floppy without traction. So I prefer to add lateral traction. Once again, trying to do a fold if possible. And you can see here that your initial trimming and injection is very important to avoid catching the muscle. Therefore, we will use the purple one, the last one, to go to the edge which is here down in the bad gravity side. We prefer for this the clips that are easy to move and to turn by ourselves because it's a little more precise. And I try to do it on the edge, but at the oral side, which will be a little more difficult to achieve. And once the 4 points traction is done, you can see here that we have an initial traction, but it's not very strong. The field of view is not clear enough for me. I really think that we can get better thanks to the rubber band opposition, the rubber band traction to the opposite wall, if possible at 90 degrees. I mean exactly on the opposite side of the colon. So we will fix the rubber band on the opposite side. We will suction the air in order to have a better traction on the opposite fold, and in order to be able to create traction by inflating the colon. And now you can see that the field of view is far more better. It's opening the field, it's tracting all the fibers, and I re-inject only once, not really precisely because the field of view is very large, and therefore it's the beginning of the cutting and the dissection phase. But here you can see that the edge is really open and it's easy to cut a lot of fibers. And thanks to traction, you can feel it. The lesion wants to be removed. She tried to go to the opposite side, and you just make her free, cutting the submucosal fiber. So really, it's not the same game now. But before, you should be able to do a proper incision, a proper trimming, a proper traction device placement and setup. And all these things need a lot of experience with model training, with supervision to be able to set up it. But once it is placed, you can see that the game becomes more easy and usually goes faster. It is important to talk about speed in this case because it's a granular LST, which is not malignant, with a very low risk of T1 cancer under 1%. And in this case, there is a debate with piecemeal EMR. En-bloc EMR for this lesion, which in fact is 4.5 centimeter, is not easy to achieve. Possible sometimes, but not easy, and absolutely not easy to predict. So here, the debate depends on the speed of your resection. If you take 3 hours to remove this malignant lesion, probably piecemeal EMR is the best option. But if in this case, like here, you can do the complete resection with R0 margin in 19 minutes like here, ESD is the best option probably because the risk is low, the technicity is not so difficult in this case, and you can achieve the resection with R0 margins and therefore avoiding the follow-up at 6 and 18 months that is needed after piecemeal EMR to detect recurrences. So here, I use, thanks to traction and thanks to the fact that I'm not afraid of losing traction, because if I lose too much traction, I will be able to use the tightening system of Attract. I do it in the easy area. I mean, in the edge, which is far from the gravity, because the lesion is opening by herself. And here, even if it's difficult at the end on the bad gravity side, I will be able to create new traction thanks to the tightening of the device. So without this kind of device, I should probably perform first the area which is not in the good gravity, so on the down left part of the picture. But here, even if I lose too much, I will be able to tighten the device and increase again the traction. So I choose to do the fastest way first. It means the good side, which is helped by the gravity. So thanks to traction, we can do the easy part first. If we have no traction, it's more dangerous to begin by the easy part because it's more difficult to achieve once the gravity is really bad at the end of the procedure. So once again, traction is also a way to do the easy part first and to use gravity as an help from the beginning and not dealing with first the bad gravity side, which is more difficult, but that should be first, because if you do it at the end, it will be even more difficult. So what I mean is that without traction, begin by the difficult side, the bad gravity side. With traction and with the capability to increase traction at the end, it's possible to work directly from the easy side to the difficult one, because traction will avoid a very bad exposure at the end. So here we go, doing always the same lines, which is an important point, I think. It's less difficult to repeat always the same cutting line for your brain. You are less tired if you repeat always the same thing than if you should think every time which line you should do. So here, I like it, for me at least, to repeat always the same movement. It's easier for me than changing the area every time. So once I'm in a good position, I try to repeat the same line every time because I save energy, and this case is not so difficult. But in a current morning, we have 4 or 5 cases in the unit, so every time we should save energy and save to be ready for the difficult case in the morning, and try to do the simple one really smoothly, without any surprise, without any unpredictable area. And when you have a procedure that is going exactly like you want it to do, with the strategy you decided from the beginning, you save a lot of energy compared to adapting yourself to many unpredicted problems. So it is also, I think, a force of a strategy which is always the same, is that you will always do the same thing. It is a kind of routine procedure. The nurses are used to what you are doing. They are not afraid of what is, and everything is going exactly like you describe it. So here, despite my effort, you can see that my knife is fixed on the clip in the last clip. So I should work a little to go deeper in order to avoid damage on the specimen by cutting the last fibers. Here, the procedure is achieved. So the chronometer says 19 minutes. And immediately after, before removing the lesion, because the patient had antiplatelet drugs, we decided to close this area in the right colon of more than 4 centimeter. The specimen is 5.5 by 4.5 centimeter in the right colon. So we decided to close this area with clips, but to avoid slipping, and because the new clips with possibilities to catch the tissue are not available now, we do this small incision around to allow and to facilitate grasping the tissue without slipping for the current clip we have. So you will see here, once the incisions are done, we use the clip. We catch one of the small hole, and we try, if possible, to find a second one, but sometimes it's not needed. If you have one, you don't slip, and therefore you are able to close all the fold. Even if the closure is not perfect, I really think that closing the fold itself could reduce both the risk of delayed perforation, which is really low, it's clear, and I'm not sure it's medico-economic to close the area. I really accept the criticism on this, but at least we are more sure of our procedure, reducing the risk of delayed perfo because the fold is closed on itself, and also because you probably do a compression on the feeding vessels, reducing the risk of delayed bleeding also. But in the literature, it's not really not clear that it is helping to do such a closure. It's more a believing that really scientific data, but at least in my experience, I prefer it to try to let patients go back home in the same day with ambulatory approach. I prefer to close the area first. So here it's the end of the procedure. We use the small grasper to catch the clip, which is on the opposite side. One of the advantages of the multipolar traction strategy is also that you are able to remove the lesion. You don't have to look after it in the right colon because it stays where you fix it. And after, because it is fixed on 4 points, like a wallet, relatively small, it's easier to remove and to catch it and to remove it to exit the lesion and to fix it. So it's close to the end of the procedure. Sorry, it's the day of children, so I have my two children. They want to say hello. J'ai presque fini. Laisse-moi 2 minutes, j'ai presque fini. Dans 2 minutes et je t'explique. The specimen is here, and you can see the specimen 5.5 by 4.5 centimeters, 19 minutes. and it was low-grade dysplasia with R0 resection. So finally, colon ESD is sometimes not so difficult, but it's very difficult to predict it. So if you have a low experience, never begin alone without somebody to help you if it's not an easy case. Many tricks exist for increasing speed, but traction is the best one. It improves a lot the speed, and multipolar traction is better. Sometimes initial traction is enough and we don't have to tighten the device. And therefore, easy ESD allows to treat R0 large lesion without malignancy. It allows to skip 6 and 18 months follow-up. It decreases the impact for the patient, for the environment, and the cost of the global management of the patient. So ESD is a good way to reduce the follow-up, but it should be a quick procedure. If it takes 3 hours and you can treat only one patient instead of 4 by PEMR, piecemeal EMR, it's not a good idea. So thank you very much. Sorry for the disturbing noises from my kids who are here today at home, and I hope it was a good episode for you. And we see you next time and with the next episode. See you. Bye.